We looked at early VTE chemoprophylaxis within 24 hours of surgery after spinal cord injury. And the question for me was, is it safe and effective? So again, here are my disclosures. So spinal cord injuries, as you know, occur commonly, relatively in the United States, especially with young males, significant disability and mortality. And they're at high risk for secondary complications, especially with VTE. So, some of the publications have previously shown that it could be up to 50% without prophylaxis. So the current spinal cord injury guidelines recommend that chemoprophylaxis is done within 72 hours of injury. Now, at my institution, we've been doing this for the last several years where we, after surgery, that they're in the neurocritical care unit and they start chemoprophylaxis within 24 hours. And initially I was a little shocked and I resisted at first because I didn't know what the safety was of it in recent surgical patients. And so I wanted to then look into the results. So this is a retrospective study of 97 consecutive patients who underwent surgery from 2013 to 2018, acute traumatic spinal cord injuries at a level 1 trauma center. We did have some exclusions, so patients below 18, anybody who had some sort of hypercoagulability, conus medullaris cauda-equina syndrome, just to keep things uniform, and then also individuals who just didn't get chemoprophylaxis after surgery. So all of these patients received chemoprophylaxis, either sub-Q heparin or low molecular weight heparin. The vast majority got sub-Q heparin, and then SCDs during hospitalization. Duplex ultrasounds were performed to diagnose DVTs, and then if indicated, then a CT angio was performed to diagnose PE. And so the outcome measures for this study was, during the index hospitalization, what was the VTE rate, drain output, any complications, medical and surgical, as well as hospital length of stay. And so we did the appropriate statistical analysis to detect differences. So here's our data. So for the most part, there's no differences in terms of age, gender, in terms of injury. But then we had a lot more Asia A patients that underwent surgery, especially early surgery. And then as compared to late, and that's likely due to the severity of the injury. We try to get to these surgeries as soon as we can. So the surgery was performed on average 25.7 hours after admission to the emergency department. The early cohort was slightly shorter, so 23.7 hours. Standard would be 24 to 72 hours in terms of the definition, and then late would be beyond 72 hours in terms of when they obtained the heparin. Not when they had surgery done. And so I divided up the three groups that way. But there were really no statistical differences, but in the early cohort, surgery was done earlier. Now, in terms of the VTE rates, so for DVT, there was statistically significant but low numbers of DVT and PE when you compare the different timing. So less than 24-hour, we only had 2 DVTs versus 6 in the standard 24 to 72-hour group. And then in VTE, we had 3 versus 7. And that also kind of is associated with DVT and PE. There were no cases of takebacks for hematoma or seroma, and when you looked at the drain outputs, there were no difference in terms of drain output. When you look at the different various early versus late, there was also a statistically significant difference between DVT and VTE, but again, the numbers are low. These are low frequency events, and no episodes of take back to the operating room for hematoma or seroma. And in terms of medical complications, there were no real differences between the groups, no differences in surgical complications, although there was one reoperation for a late patient. And the length of stay, ICU stay were similar. So in terms of limitations, of course, this is a retrospective design with inherent biases, with small sample size, with low VTE rates. So this could all definitely influence results. The selection bias definitely is there with surgical patients, and we're seeing a lot more AGAs doing surgery earlier and also giving the heparin within an earlier time frame. So that could influence things. But I was able to show that at least it was effective in the patients that we saw with reducing the VTE and DVT rates once you start it within 24 hours, and that it was relatively safe with no postoperative bleeding complications that we could detect, no increased rates of medical or surgical complications, drain output, and length of stay. And potentially this could be translated clinically into other high-risk populations such as cancer, spinal tumors, things like that, if they have a high risk of DVT, VTE as well postoperatively due to their pathology. Thank you.